So good afternoon, everyone. It's a pleasure to be here. My name's Lance Becker, and haven't had the privilege of getting to know most of you. And very quickly, I want to find out who you are. Can I just do a quick poll? You can use we don't have a digital device, but we still have analog devices here. Just a show of hands. Do we have students here? Are there students? Terrific. And do we have some doctors here? Do we have doctors? Oh, there's a lot of doctors here. Any nurses in the audience? What about just general people that are interested in this? That's terrific. Do we have anybody that's people that have had a near-death experience? I know we did. Terrific. All right, so we have a really diverse group here. And what I'm going to do is very quickly try to bring everybody kind of up to speed on what this field of science looks like, starting with pretty basic stuff and moving up so that the rest of the speakers will be able to put their comments in that context. And so first, my disclosures, and I now use this as to go into my most important disclosure. You can see that I spent, just for those of you who don't know me, I spent 17 years at the University of Chicago, 10 years at the University of Pennsylvania, and for the last 4 years I've been at Northwell Health as the chairman of emergency medicine there. And of course, part of my job is to get grants, and I do that, and you'll see those up there. But what I figured out is I have a much more important conflict of interest, which is that I have an intellectual bias. And I'm going to be very frank about that, okay? Because an intellectual bias is much stronger than any other type of bias that I've seen in the field of science, and that is that, as Sam alluded to, right now we typically will pronounce people dead after they've experienced a relatively short period of being without oxygen. And it is my bias that there is much more we can do to dramatically expand that survival window. So I will own that bias, I will try to defend it, and you can feel free to challenge me about it. Now, this was a Newsweek piece that was done, and the reason that it did highlight some of the work that we do and some of the work being done by laboratories around the country. And here you can see the title, "This Man Was Dead, He Isn't Anymore." And I use that because I really think that's the fundamental essence of resuscitation science, and that's what we're going to be talking about here. And in terms of how I came to this and the way the field has progressed, one of the things that we'll be talking about is sometimes it's hard to know when a person is actually dead. So just a little bit of background on that of course we've got this thing in our chest that beats and is our heart and drives all of our blood flow. And when I came to the field of cardiac arrest, it was essentially all about getting the heart restarted. So the idea was that if, as a doctor, I got the patient's heart restarted, I had been successful. But what we've learned in the last 20 years is there's another organ that we really need to begin to focus on, which is the brain. And so I want to submit to all of you that there's been this transition, and you can see this transition in actually the legal definitions of death, that there was a legal definition of death that when the heart stopped, the person was dead. And we know that's obviously not true. We now believe that when the brain irreversibly stops, a person is dead. And what we find ourselves in right now in the year 2019 is this sort of uncomfortable space where there's kind of this zone in between, the gray zone, where we're just not quite sure. And what I want to submit is that that zone is much bigger than we think, and that the opportunities to resuscitate people are much larger than we also think. So I want to move right into sort of the model, the way I think about resuscitation, which is you've got basic CPR. And a quick question, how many people in the audience have done CPR on a person? It's a lot of people who've done it on a person. Well, good, I feel much safer. And I do feel that everyone ought to be able to do this. And I wouldn't want you to leave without at least that being highlighted. And so I'm going to talk a little bit about the critical elements, chest compression, defibrillation, airway. I'm then going to move really quickly to what I call advanced resuscitation. These are things that you might not get in every medical situation. And there are things like cooling, advanced monitoring, ECMO and cardiopulmonary bypass, which I'll talk a little bit more about, beginning to deal with reperfusion and post-resuscitation injury, which are the things that happen as the physiology goes on after cardiac arrest. And finally, I want to take us to the future, just a little bit, at least the future that I see, where we'll be dealing much more with brain resuscitation, specific cocktails, and sort of taking on this issue of what is irreversible death. What is the point of no return? So very quickly, I want to turn now to basic CPR for just a moment. And many of you have done this. This is sort of the hallmark. If there's one thing to take away from anything I'm going to say, it's that if you have an opportunity to do this for a person who's pulseless, this is the very best thing you can do to save that person's life. And that this has saved literally tens of thousands of people. You put your two hands in the middle of the chest and you push hard and you push fast. All right? And we should actually all know how to do it, and we should teach everyone how to do this. Now, of course, another thing that's quite important is airway and breathing and getting oxygen into a person. And we know that there are techniques for this, and many of you have been taught those techniques, and they likewise are a very important part of our basic CPR. And finally, when the heart is in a specific type of rhythm from a cardiac arrest that we call ventricular fibrillation, there's a technique of providing electricity to the heart, of shocking the heart, that can essentially restart that heart, called defibrillation. And there are now automatic external defibrillators that are available. They're in all the airports. I had the privilege of being involved in one of the first studies where we placed those automatic defibrillators in O'Hare Airport, Midway Airport. And over the course of that year, it saved 11 people's lives, where previously there had been a survival rate of 0 within those airports. And so that is why there are now defibrillators in buildings like this and in airports. And another very important part of basic CPR. Now, I would be remiss if I don't highlight that these basics are really the fastest way for us to save people's lives around our communities right now. That as we think about it, if you say, what can we do right now to save more lives in New York or in any other community? It's get these basic things out to more people. And I think we all have an obligation to work on that. But I also want to talk about some newer concepts that are coming along, about teamwork and the idea of some metrics. So here you can see this hospital uses Formula One tactics to help newborn babies. Well, what are they doing? What we figured out is it's actually doggone hard to do a resuscitation. It's really very challenging. I want to say more about that. And you cannot fix what you do not measure. This is one of the things that I believe, as someone who now works in organizations that are trying to be better and better and better, you've got to measure it. So a little bit about that. This is a monitor defibrillator, and this little hockey puck right here is actually a device that sits on the chest, and as you do CPR, it can measure each compression that the person is getting. So now we have this compression monitor, and you can actually see those little things going up and down there. That's each beat, and you can see when it goes to a flat line, it's because no compressions are taking place. So we now have the ability to monitor our performance. It's very important, but very few cardiac arrests today currently get any type of monitoring. 99% cardiac arrests are simply unmonitored. And I think that's a mistake. Now, what else could we do? And has anybody seen one of these? They're all over. Look at them. They're all over. They're in our emergency room. So I want to tell you just a little bit about our video initiative. And Dr. Lee is in the back, and he's been very involved with that, along with some of the other members of our team. And what we're now doing is actually videotaping our actual cardiac arrests. These are not simulations. We have over 260 of these that we videotape. And when the cardiac arrest starts, we turn the camera on, we run it, and we review them on Thursday morning as a big team. And here you can see Dan Ralston with a video, and we're going through what happened. And everybody joins in that. And so what we've developed is like a learning curriculum where we look at how we do. We find areas for improvement. We try to improve, and then we continue to monitor. And I just want to show you some data that was presented yesterday at the American Heart Association. These are the results of this program so far. And what you can see is that our rate of return of spontaneous circulation, that's this ROSC thing, has gone up from 26 to 41%. But most satisfying to me is our rate of survival leaving the hospital has gone from 3% to 7% with patients that are coming in over this period of time while we've been working on this. So I just say that to highlight how much better we could do in this country, even with the basics. So now to advanced resuscitation. And I want to focus on 4 areas. One is on cooling, one is on performance and monitoring, on the use of ECMO, and on reperfusion injury, and moving into the things that are going to be further advanced in terms of the therapies that are coming down the line. So cooling. How many of you have just heard of cooling? You know, that you can cool people down. Good. Many people are familiar with it. So what we know is that currently it's a great benefit to cool a person down after a cardiac arrest, particularly if they have any evidence of neurologic dysfunction. And we target, it's very mild cooling to about 33 to 36 degrees for about 24 hours. Now you can tell there's a lot we don't know. The one thing that I think everyone agrees with is, as part of it, we want to avoid letting that person develop a fever to become hyperthermic. It's very bad for the brain. And so it looks kind of like this. This is like an external wrap that goes on the patient, and it has ice water that goes through it. It cools their temperature down, and then it controls that so that they don't overcool. There are other ways you can cool too, with IV saline, with catheters. There's a whole series of ways, and it's being you should know there's a very active area of investigation in this country right now. And I believe we even have representatives from some companies that are thinking of innovative ways that they can cool. This was a study that, again, just was presented in the last month from France, where they showed again the power of cooling in being able to protect individuals after a cardiac arrest, and it mostly seems to protect the brain. Now, what do we do about monitoring how we do? And you've sort of already heard a little bit of my bias, that I believe that if we don't monitor, we don't always do the best job. And so, what else could we monitor though? Because maybe we could go beyond this. If you think about this, this is sort of a hockey puck on the chest of a patient. Well, is that the best monitor, really? Well, there was a lot of data that was presented at the American Heart Association that you could start to move to see if those chest compressions are moving the blood around. So you could measure something like blood pressure. Well, we could go further. Remember, we want that blood to go around, and we want it to go up to the brain. So we could measure oxygen in the brain with a technique that Sam has thought a great deal about. And it's called NIRS, or near-infrared spectroscopy. It's a way that we can actually see if what we're doing to the patient is getting the job done and getting the oxygen up to the brain. And of course, I think we may be able to eventually even go further. These are mitochondria, and no talk of mine is complete without mitochondria, so I just want to say I had to do that to complete my talk. But those are sort of the power engine inside the cell, if you will. That's where all the oxygen that you breathe in is going to, okay? And so we could have a mitochondrial meter, and indeed we're working in our laboratory on how we might be able to do that, because we could learn other things about how the cell is behaving. And I'm very agnostic. I think all of these monitors may be very, very useful, and monitoring represents a major opportunity to improve our resuscitation, particularly if we take the viewpoint that we're going to use the monitor in the following way. We've got this monitor, say, of the brain, and let's say it's not so good. Then what we should do is change the way we do CPR. Now, what I just said there is quite radical. And the reason I say that is right now the way CPR is taught is it is taught as a one-size-fits-all therapy. So when all of you took your course, you got a mannequin, you compressed it one way, a certain rate, a certain depth, and it turns out there's other things that we could do to optimize that. But we can't do that without a monitor, and if we want to get into the area of customizing our resuscitation for each patient, does a big patient need the same rate as a small patient, or a man, or a woman, or an older person, or a younger person? We need to be able to customize our resuscitation, and this monitors have the ability to do that. Now, a few words about this very new technology called cardiopulmonary bypass. Sometimes it's called ECMO, or extracorporeal membrane oxygenation. Essentially a heart-lung machine. They're in almost every hospital around the world. And what we're now doing is bringing those to the bedside of a patient in cardiac arrest and rapidly putting them on this kind of support. And we are doing that at Northwell. I should have warned people. I hope nobody has a weak stomach on this, because this is actually Demetrius Yiannopoulos in Minnesota. That's Demetrius sort of standing over there. And all that red stuff there is, that's not like for your benefit, okay? That's what I'm trying to say. That's like, so I just want everybody to know, it's like, it's a major thing. You don't do this with kind of just two hands and no equipment. You can see all the equipment that surrounds Demetrius there. But this is the best way to get reperfusion, certainly to the brain. We have to be honest, it's technically difficult. It's hard to do. It's invasive, it requires a big team. You can't, this is not a one-person job. It can't be done with one person. Right now we only do it in very, very selective patients, and obviously it's resource intensive, it costs money. But there's no question that this is moving out into the world. So this is another picture of ECMO being performed. Does anyone recognize the venue? Somebody knows back there. Say it loud, Tom.
It's the Louvre.
It's the Louvre. So this is the SAMU in Paris, and they have a team that places patients on emergency cardiopulmonary bypass. And they are cannulating a patient in the Louvre, right there. We know this is growing. It's growing worldwide. There's no question it's accelerating, and it's accelerating everywhere. We've got a lot to learn about it. But I'm going to say this, it is still technologically very primitive. Very, very primitive. Like, we're still using kind of these big machines, and we got to make that better. But it does offer the opportunity that it very, very significantly enhances survival in a way that CPR will frequently fail. And by that I mean survival rates that go to 20 and 30 and 40%. So now, I want to begin to sort of wrap up here with the reperfusion injury. And I got this yesterday out of Wikipedia. So, you know, reperfusion injury, sometimes called ischemia reperfusion or reoxygenation injury, is the tissue damage caused when blood supply returns to tissue after a period of ischemia or lack of oxygen. And I had the pleasure of sort of really writing a lot and doing a lot in the laboratory. We defined this in cells and mechanisms for it. We're not going to go into that. It clearly happens in cells. Not controversial. It also clearly happens in the heart. Not controversial. A little more controversial, but I think the evidence is very good. It happens in the brain. And so as we talk about what the limits are going to be to recover a brain, this is my image of the brain on fire, okay? That very much reperfusion injury is indeed the brain on fire, and I'll tell you why I say that. So here's how this works, and this is not obvious to everyone. So this is a patient's brain, and now something bad happens, and you take away the oxygen. And it could be a cardiac arrest, it could be that they bled out, it could be all kinds of things that they now no longer have oxygen in their brain. And after a few minutes, in fact, if we could see that brain, it looks a little funny. Okay? There are things going on and signals going off in that brain, and there are messages going off in that brain that are quite abnormal. So now they come to my emergency department. What do? So at this point, I know what I do, and you all know. You've watched ER. You know exactly what's going to be done. I'm going to give them back oxygen. And not only am I going to give them back oxygen, I'm going to give them, like, not a little bit of oxygen. I'm going to give them a lot of oxygen, right? And so what I'm hoping for is I get this result, that now that brain goes back to normal. But reperfusion injury occurs when, as opposed to that brain going back to normal, we now get a new reaction that begins to take place after the introduction of that oxygen. And that brain begins to literally go on fire. Now, the reason that I say on fire is because fire is an oxidation event, okay? And to a large degree, we believe that reperfusion is driven by an oxidation events as well. So, we know the mitochondria plays a major role in this. And I want to highlight that for a short period of being without oxygen, you don't have to worry about this. It's not an issue. But as the period becomes longer and longer, it becomes an issue. But I want to tell you that all the evidence is that this is treatable, that it can be treated. There is no reason to believe that it is irreversible. So we want to rapidly reperfuse, but without a lot of reperfusion injury. So what can we do? Well, we know cooling works for this. And cooling is one of the things that essentially proved that reperfusion injury exists in the brain, because when you cool someone down after they've had a cardiac arrest, we know they're actually better. And one of the things that we're now beginning to try to develop is what we call a reperfusion cocktail. Sort of a number of agents that we mix together in an attempt to control the reactions that drive this reperfusion injury. So finally, I want to wrap up with brain resuscitation and these cocktails. So right now, the cocktail that we're developing, and I think that you're going to hear from the Yale group about a cocktail that they've talked about, and at the Heart Association, there was another group that's looking at a cocktail, is one that's designed to hit a number of metabolic pathways. And so they have to fix the ionic disequilibrium of the cells that normally have sodium in one compartment and potassium in another compartment. Everything's all switched around, and that has to be fixed. We know that we need antioxidants to take care of that oxidation event that I was talking about. And we need mitochondrial medicines that are targeted to get into the mitochondria so the mitochondria doesn't keep doing a lot of bad mischief to the cell. And finally, we also need to protect the cell membrane. We need critical cofactors, and we are now attempting to put these agents together. And if we're very lucky, what we are going to do is put them in with the cardiopulmonary bypass machine. They get mixed together, where because that machine is pumping 5 liters a minute through the body, it can rapidly gain access to the brain, go into the capillaries of the brain, and become active and protect the cells of the brain during resuscitation. And so this is the system that we are very actively working on in the laboratory, and some of the members who are working on it are sitting in the back. And I hope to be able to talk more about this in the future. So I just want to wrap up by saying that we've made huge advances in resuscitation. I've tried to give you like a snapshot of basic CPR, advanced resuscitation and future, and a little bit about some of the controversies. We know that cooling and a cocktail and a pump are going to be very integral to the future of resuscitation. But I just want to leave you that I believe this death window, if you will, is rapidly opening up. And I look forward to hearing the other speakers. And I think this is a time where we should be very, very optimistic about what the next decade is going to bring us. Thank you very much.